So good morning, everyone. All right. So fortunately or unfortunately, I'm not a clinician. So I'm actually an AI scientist from Singapore Health Services, and the AI lab is led by Professor Daniel Ting. So it's always an excitement to actually share about large language models and AI, especially with the Gen AI explosion, right? So without further ado, I'll just go into the presentation. So I have no conflict of interest. So just a quick check, right? How many of us are actually using large language models day to day, right? How many of you guys, right? I see a couple of hands. So I think the idea of large language models actually kind of had its inception in 1990 actually, in terms of the statistical language models. And over the 3 decades after the inception or the development of transformer architecture by the Google team, they then had the pre-trained language models, and then we move into the large language models. So if you look at the large language models, they are now seen as universal solution experts, right? Basically, you can ask it anything and you would come out with a response. Whether it's factual or not, that's another discussion for later, right? But you get a response. So here are some like popular LLM engines, right? That is already surfaced now. I mean, it's not an exhaustive list, but if you were to look at it and how you categorize LLMs now is that you actually have them as closed source LLMs and open source LLMs. So what's the difference here is that open source LLMs are those that you can potentially locally host if you have enough compute resources. But if you look at the closed source LLMs, they are actually hosted elsewhere, and you only can access them via API calls, and that leads to a lot of data issues and safety and ethical concerns that open source language models can easily mitigate. So here are just 2 papers that has been published in Nature journals, and it's actually a primer papers, and one of the review articles has actually been published by my team, and a co-author Ting Fang is also here. And this paper has actually garnered over 2,000 citations in less than 2 years, right? So it just shows how prevalent the use of large language models are going to be in healthcare in general and also in ophthalmology. So just in a nutshell, what are the applications of LLMs in healthcare, right? It is actually quite diverse and quite exhaustive, starting from administrative tasks like doing discharge summaries or generating operative notes, to even building a research assistant tool for doing literature review. And also, if you want to look at the highest hanging fruit, is actually looking at clinical management and coming out with treatment plans and protocols. So, but I believe now, when you're using large language models, we are now very familiar with the limitations of it, right? Whenever you talk about large language models, you will definitely have to mention the term or the word hallucinations, right? If you don't say hallucination, means you don't actually work with large language models. It comes to that, essentially. And these hallucinations lead to clinical inaccuracies. And then also, the fact that these large language models have been pre-trained on past data, they actually lack recency in terms of the knowledge, right? And also the lack of interpretability. If you were to look at the architectural design of large language models, they are actually basically predicting the next probable token, or in the case, words, right? So you don't really have the explainability to these large language models. And of course, the ethical and safety concerns depends on which engines you're planning to use, whether it's the open source or mostly related to the closed source models. But these limitations can be mitigated by few techniques, right? One is prompt engineering. Next is actually retrieval augmented generation, which I'll talk about later, and also fine-tuning and pre-training. And pre-training in the sense that you can actually do continual pre-training with open source models. And actually, I just wanted to add that the first 2 options actually only applies to closed source models. You won't be able to do fine-tuning or pre-training with closed source models. You only can do that with the open source models. So what is RAG, right? So this is actually the formal definition of RAG, essentially. But to me, when I want to actually talk about RAG, I actually try to simplify this as like an open book exam, right? I mean, everybody is familiar with this. You actually have a system of, basically when you're doing an open book exam, you're actually having a student answer a question with referenceable notes and textbooks, for example. So basically, a student will then do the information retrieval and then generate the answer. But when you look at a RAG with the LLM, we're actually going to split these 2 rows and these 2 rows as a retrieval agent for the information retrieval, and also to generate the answers then when you use the LLM. So how does that look like, right? So first you have a user query that goes into a retrieval agent. So I say retrieval agent because it's a very generic term to mention. It can be a Python code, it can be a Python script, or it can be an LLM essentially also. But what it does is that it's going to convert the user query into a retrieval query and extracts the relevant information from the external knowledge base. And then passes the user's query together with the external extracted information to the LLM, and effectively you get the answer from a user standpoint. But how the LLM is going to process this, right? So this is where you actually have a system prompt or an instruction where you can actually assign a role, whether it's a medical chatbot, and then you can inject where you want the retrieved text to be or the contextual information, and followed by the user's query. So there are many different types or different techniques of RAG essentially, right? So I'm just going to briefly mention all this. All of these methods are actually kind of humanized in some extent, right? If you look at it, it's corrective RAG, self-RAG, speculative RAG. They kind of humanize this to make sure that the LLM is actually validating and correcting itself and making it better. So this, and actually I have a link below that actually is talking about 25 types of RAG essentially. So I'm not going to bombard you guys with all this information, right? So I'm just going to talk about the agentic RAG, which is what the entire space is moving towards. I'm not sure how many of you are familiar with Manus from China, and also Anthropic's computer use. I don't know how many of you are using that. Basically, you can actually automate your task using such agentic LLM engines. So, but what is it doing in RAG in ophthalmology, right? So, unfortunately, this is just a quick PubMed search, and there's only 3 articles that's being published in ophthalmology, right? Retrieval, augmented generation, and ophthalmology is the search query. And we only got 3 papers so far. So what's the reason why we don't have so many publications in this space? So then moving to the cons of RAG. So basically, RAG is actually data dependent. So if you have poor quality data or outdated data or irrelevant information, you then get misleading outputs. Followed by that is high complexity. So if you look at it, there is a retrieval component, and then there's an interaction with the knowledge base. So this actually leads to a complexity of the pipelines using RAG. And of course, it's scalability. If you're looking at different data types like tables or even PDF documents that have embedded tables and text and images to it, it gets very complex in terms of how you want to scale the solution. And then lastly, the latency, right? Because you actually have a full-fledged what you call retrieval pipeline and complex LLM pipeline that actually limits its application into real-time applications. So just a quick sharing of what we have done in my team as a pilot study. So we actually wanted to develop and validate a lightweight LLM for clinical decision support using ophthalmology case scenarios. So basically it's a case scenario. So conventional approach is actually what it does is that we usually have a patient case as a query, and then the knowledge base is based on the guidelines and protocols, and the output is actually a surgical fitness assessment and medication dosing optimization. So why I chose these 2 outputs and why I've linked papers below is that these are the non-ophthalmology work that my team has done. And for the surgical fitness assessment, it just got published today in NPJ Digital Medicine. And the preprints are here. So, but for this use case or this pilot study, what we have done is a different approach, right? We look at a non-conventional approach where we are actually using patient case to reference with patient case, and then provide the top 3 differential diagnosis and treatment plan and triad disposition. So this is just a preliminary results that we tested with Llama 3, 8 billion, Mistral model, Titan, Text Express. So if you look at the native accuracy, is actually the LLM's native responses, and then the RAG accuracy is with the knowledge base or the past patient case information. So we actually tested this on 18 patient cases, and of course, Mistral as the better performing models. And this work is actually been published or submitted to as an abstract to ARVO. So if you guys are going to ARVO next month, hope to see you there and we can discuss further on this. But I just wanted to close off, right? I think because most of you are mostly clinicians and physicians and ophthalmologists here. So I just wanted to say that the go-to method to actually make LLMs to reason was actually using RAG, right? Because you basically have a knowledge base, you have clinical groundedness, and then you get a contextual understanding in terms of generating clinically relevant responses. But what is happening now is that we are actually looking at reasoning models, right? Now we have DeepSeek, we have O1 models from OpenAI. So my question to you guys, and that's what I'm going to end off this session with, is that are these reasoning models or logical reasoning models equivalent to clinical reasoning? So this is something that I'm not sure. I'm actually working on evaluating this, but happy to hear from you guys. What are your thoughts on this, right? So with that, thank you, and I want to extend my acknowledgement to Professor Daniel Singh.
Any questions or any comments?
Wonderful session for Dr. Rajiv to ask whether the anemic changes or IDDM versus a NIDM diabetic. Now, our objective is to target the retinal blood vessels window, because the blood cells which are flowing there would give a lot of information for anemia, any other disease. For example, leukemia, you can freeze the white blood cells, and the red blood cell characteristics, platelet characteristics, and for the sludging of the blood vessels, blood circulation in the diabetic, what stage of diabetic, duration of the diabetes. Now, whatever is obvious for clinical thing will not give too much information, but if you can pick up those cases in the pre-diabetic or before the advancement of diabetes or anemia can happen, I think that will be a wonderful thing.
Thank you, sir.
Yeah, octa images or some nuances in the imaging system would give a better response for those things. Thank you.
Not really. One more question I want to ask.
The question whether what you talked about the models, will it be useful in clinics?
Right.
And my answer is full yes. Any modern clinic is not a one-person show anymore. You're a teamwork of people, some doing intake, then the second phase intake, and then you come to the specialist. And because you're dealing with humans, you have a lot of inconsistency.
Right.
And I think these models will harmonize, make it more equal and more predictable. So yes, and it will get better. I'm a full believer. We're working in our clinic in these models, etc. We're doing summaries of all our old patient files. We're practicing now with true large language models to do the questionnaires to the patient, but we have our assistants doing the actual questionnaires for quality control, and we believe in it. It's the future.
Yeah. I think I just threw the question as a curveball, actually, just trying to get affirmation from clinicians essentially, right? Because that's what I actually have to face. So it's good that we are seeing a lot of this acceptance of LLMs now, right? Thank you.